Good afternoon. It's time to start our next session, which is session 3, Interventions to Address the Diverse Needs of Cancer Survivors. I think after hearing this morning's sessions, I think this would be a nice complementary session coming up in relationship to the other sessions. Our diverse needs include many things, such as geographic access, comorbidities, accelerating aging. And we know that when we talk about diversity and disparities, we often think about race and ethnicity, which is very important. I would take a poll, but I'm not going to do that. But I'd like to know how many people do know that there is a bill circulating that will limit the collection of data on relating to racial disparities for federally funded projects. Yep. So this is, just so you'll know, Senate Bill 103, Prohibition in the Use of Federal Funds. In short, federal funds may not be used to design, build, maintain, utilize, or provide access to a federal database of geospatial information on community racial disparities or disparities access to, says affordable housing, but you know if you're on a federal government list, you are on a federal government list. So just something for you to think about as you go forth and we talk about diversity and disparities are incorporated. So we'll get started with our first speaker, who is Melinda Stolley from the Medical College of Wisconsin. She'll speak on meeting the needs of diverse populations.
Sorry. I know. I'm talking about how anxious I am to be speaking in front of my peers. Truly. Thank you for inviting me to be part of this. It's really such an incredible team that we have here. So as Lucille said, I'll be talking about meeting the needs of diverse populations. And I want to start with a very quick overview about cancer disparities because that underlies much of my talk today. And National Cancer Institute defines cancer disparities as adverse differences in cancer incidence, prevalence, death, survivorship, and burden of cancer or related health conditions that exist among specific population groups in the U.S. These are more common in low-income and racial ethnic minority populations, and it's owing to multiple complex and interrelated factors that really run from the individual through families, healthcare systems, and policy. And I have just two graphs here with SEER data for breast and prostate cancer that show you, let's see, is this, here we go, that show you the disparities that we see particularly among blacks and whites in terms of mortality. Oh, I have to go back to them. In terms of mortality between blacks and whites. These also exist if you looked at lung, colorectal cancer, nearly every cancer we see these types of disparities. So when you think about those disparities and then we look at projected cancer incidence, this was a paper that was in JCO, looked at projected cancer incidence between 2010 and 2030. Apologize for the logo, that was supposed to be cut off. And what we see is that there'll be a 45% increase or a 7 million case increase in cancer cases in the next 20 years. Most of those will be among older adults, but you also, and minorities. And so you see that really we'll see a huge increase in cases among Latinos and Asian Pacific Islanders. And Latinos, it's a young population living here in the US, so certainly as people age up, we're gonna see higher cancer incidence. So how does that relate to obesity? Well, as we see an increase in cancer incidence, we're also seeing, and it doesn't parallel in terms of time, but between 2000 and 2010, or I'm sorry, 1997 and 2014, Heather Greenlee looked at obesity prevalence in cancer survivors and the general population. She found a few important things. One is that obesity prevalence was rising more rapidly among survivors compared to those in the general population. And then when you look at racial ethnic group, how do we go back? There we go. When you look at racial ethnic groups, we see that there's higher obesity among Hispanics and non-Hispanic blacks. And also when they looked at who was sort of increasing in obesity prevalence at the highest rates, It was those surviving breast cancer, colorectal cancer, and non-Hispanic Blacks. Looking at survivors and then also within the general population, because the people who will be getting cancer in the general population, we also see these huge disparities in obesity, in that Blacks, particularly women, you see much higher rates of obesity. This is obesity, not just overweight and obesity, but obesity alone, that nearly 57% of African American women are obese in the general population, and among Hispanics, almost 46%. There are also disparities within men. And Native Americans, they did not have by gender, at least I couldn't find it easily. You see a rate of 42.3%. So it shows that there's a huge problem of obesity within our minority communities. Feeding the obesity, so to speak, no pun intended, we want to take a look at sort of behaviors, results of those obesity among minority survivors. And there's been some nice research looking at this. And what we find is that there's low adherence to physical activity and nutrition guidelines among minority survivors. One caveat to note is that most of this research has been done among African Americans, some in Latinos, mostly breast cancer survivors. There are high rates of obesity-related comorbidities, which certainly is somewhat related to the higher rates of mortality that we see. And minority survivors are also more likely to report fair to poor health status compared to minority controls or those in the or other survivors. So thinking about beliefs that potentially impact behavior and obesity rates, Selena Smith, who's down in Atlanta, in Georgia, Augusta, Georgia, looked at beliefs around obesity and breast cancer recurrence, physical activity, diet. And although we can't say definitively that obesity or physical activity or diet, if you change those, will prevent recurrence, they did ask African American survivors what their thoughts were on this. And I think important to note here is that although many people did believe that if they lost weight, changed their activity or diet, that they could, I worry about this word prevent, but maybe reduce risk of recurrence, there were many that said no or don't know, which says to me, how good a job are we at getting the message out among minority survivors that obesity matters, diet matters, and physical activity matters. And later on in a slide, I showed that actually within the general population, there is evidence to show that physicians are less likely to talk with lower educated, I shouldn't start with lower educated, with minority or lower educated or non-English speaking patients about lifestyle changes. So we need to be keeping that in mind. Another belief that might impact obesity-related behaviors is fatalism. This is common in minority communities, probably mostly due to the social injustices and the fact of feeling powerless in changing one's life. But this belief that if I have cancer, you know, it's my fate and whatever happens, happens. So I do all that to set up that obesity, cancer, behaviors, beliefs all occur within a context. And I think this context is particularly important to think about when we're thinking about meeting the needs of diverse communities. Because as shown in this was put together by, there was a number of centers around the US that were addressing health disparities, not just cancer. And they created a number of models to help us understand what sort of feeds disparities. And we see that there are these upstream factors like healthcare factors, neighborhood and built environment, socioeconomic, stress, psychosocial factors, which then impact individual behaviors, which then feed disease risk, including cancer, diabetes, and heart disease. So why does the context matter? If we look at environmental contexts, we see that high segregation, low socioeconomic status, high traffic density, high crime rates, high number of fast food restaurants, low access to full-service supermarkets, and low access to safe, affordable options for exercise are all associated with higher odds of overweight or obesity. Due to a long history of social injustices in our country, minority communities are more likely to face such negative living conditions. So when we tell patients to go eat healthy, exercise more, we need to think about where they're going to be doing these things. Cultural context. Why does this matter? Well, we know from lots of research in general populations that culture influences perceptions of disease and their causes, belief systems related to health, healing, and wellness. An example here is Shariki Kumunyika, who's done tremendous work in obesity in the African American community. Once asked, one of her survey questions was, I'm not going to get this perfectly right, but basically, is it better to rest when you're tired or exercise? And most responded that rest was more important to your health than exercise. Culture also influences health-seeking behaviors and attitudes towards healthcare. If when you walk into a hospital, someone looks at you twice, wonders why you're there, directs you to the emergency room potentially when you're there for a primary care appointment, your comfort in walking into healthcare systems is going to be very different. And then use of traditional and non-traditional approaches to healthcare. Populations also vary in their historical and personal experiences of biases, which impact relationships with healthcare and research. And this is even will differ within population groups. So in our older adults, at least I have found that the familiarity with the Tuskegee trial is very high. People are very aware of that. And yet in younger individuals, I find that they will say, you know, I shouldn't trust research, but I'm not quite sure why. So we also want to be sensitive to that. And then within immigrant communities, acculturation has a strong impact on values, beliefs, and behaviors. What about survivor context? So that was missing from that first model since they were looking at general health. What matters to survivor? Well, life context matters. As I said before, in the work that I've done within the African American and Latino communities, they want to be seen not just as African American or Hispanic or just a cancer survivor, but their entire life. And also that someone talked before about the resilience of being a cancer survivor. There is also a high level of resilience of being a person in color in our country, and potentially even more nowadays. And also a focus on the assets of communities as opposed to always focusing on the deficits. Survivors are interested in lifestyle weight loss interventions. Motivators that have been found in some work by a number of people around the US for motivators of weight loss and lifestyle change among minority survivors include social support, social modeling, self-efficacy, improvements in strength and function and weight loss, very much what you see in other communities. Social support is particularly important. And then barriers, family. In my particular study, I had a woman who started going to bed at 7 o'clock at night. And I said, why are you doing that? And she said, well, my husband comes home from work at 10 o'clock every night and brings a cake home every night. And so he's sabotaging my weight loss efforts. So we need to think about that context. He didn't want her losing weight. And because he liked heavier women, and that was his impression of what health meant. And so we need to think about things like that. Comorbidities, pain, access, stigma. I call this out because not all survivors, and particularly minority communities, there sometimes is a stigma around cancer. They don't want to be wearing the pink shirt that shouts, I'm a survivor. It's a quiet, it's a personal experience that not everybody wants to share, and we need to be aware of that as we're recruiting, developing interventions, and even how and where we hold these. Let's see, what else? Why do we need programs specific to cancer survivors? And I don't know if this is just for, I get asked this question a lot within minority communities. Why do we need programs for survivors? Why can't we just do general weight loss? Well, at least breast cancer survivors, I can tell you, are interested in comprehensive lifestyle programs that are not only going to address weight and lifestyle change, but also being a survivor, having cancer, and understanding the evidence that links all those things together. What we don't know a lot about are male survivors. There's been virtually no work done within minority males. I know in terms of my personal, just started doing some qualitative work with African American men. And like Robert was saying, that sort of feeling strong and muscles, that is something that's important. So before I go into doing a very quick review of the studies that have been done, I present another model that also comes out of the Centers for Health Disparities that I think provides a really nice framework for how we should go ahead and understanding and addresses cancer disparities and obesity among cancer survivors, and that it requires a biopsychosocial framework that integrates biological, behavioral, and community-based research, which I think of as sort of a cells to society approach. And as you can see here, we start down here, right, with the cells up through the individual, physical and social context, and up to policy. Or those of you who are familiar with the socio-ecological model, the need for interventions and for our research to be multi-level. So, one slide is all you get for all the interventions that have been done with minority survivors. I left off 2 that I've done because there wasn't room and I wasn't going to make it 2 slides. But this is kind of pathetic. There are 2 ongoing from the NIH reporter, and Jean Ferrante, who I just met today, I'm thrilled, is doing a Fitbit versus smartphone-based intervention. And then Monica Baskin has a big study going on down in the South. So what we see here is nearly every single one, except for one, is among breast cancer survivors, okay? Largest sample size is 89. There are fewer among Hispanics, so we've got 4 with Hispanic, 10 with African American. There was 12 studies total. So we certainly have our work cut out for us. What are the intervention results to date? Well, we know they're feasible, they're acceptable, and at least the ones that have been published so far show that there are few adverse events. Weight loss is modest. This is not uncommon in weight loss in the general population. The DPP, which we've heard how intensive of an intervention that was, led to only 4.4% weight loss among African Americans. So far we see a range of 1 pound to 8 pounds, or 0% to 3.7% weight loss. There are accompanying modest changes in diet and physical activity. So does that mean we shouldn't be doing them? I would argue no, because there are many benefits, including improved quality of life and decreased symptom burden, increased social support and self-efficacy, decreased cancer-related anxiety, and also improved biomarkers of health and breast cancer recurrence. Gaps and opportunities. So in short, we need more evidence. I mentioned Shariki before, and there's an amazing organization called the African American, help me here, Collaborative Obesity Research Network, something like that. They did, oh, thank you. Katie gave me the thumbs up. They did a series of reviews. Actually, Obesity Reviews had a whole journal on a review of all the interventions in the general population conducted with African Americans. And as a result of reviewing all of those studies, we still need more evidence in the general population. So you can just imagine what we need within cancer survivors. Designs, there are a few randomized controls. I believe that my personal experience shows that comparative effectiveness are perhaps the design we need to choose, in that there is great resistance to being randomized to a control group. Study samples, they're very small. I think partnerships are incredibly important in terms of fostering better recruitment and retention. There's been thankfully, many of these have been done within the community, but we know very little about scalability and sustainability. No published studies on web or mobile phone based, but we'll look forward to Dr. Ferrante's study. And there's a limited focus on maintenance. Outcomes, we need to extend beyond weight and behavior to include relevant physiological outcomes, mediators of weight loss, and as I said, implementation process. And then finally, populations. We need other cancers. then other populations, and also consideration of the refugee and immigrant communities. So really quickly, case study, and I'm going to zip through this because I want to get to my closing slides. But this is a study that I just finished completing, 246 African-American breast cancer survivors. We're looking at anthropometrics, behavior, biological, and psychosocial outcomes. We partnered with the Chicago Park District. As you can see, we were mostly in the south and west sides of Chicago, which is where Chicago is an incredibly segregated city, where most of the African-American communities are. And I want to spend a few minutes, not a few minutes, like a few seconds on this. But as we developed the intervention, we used a framework offered by Matt Kreuter from Washington University to enhance the cultural appropriateness. And he makes the important point of don't equate race or ethnicity with culture. There are substantial differences within population groups. So as we enhanced the intervention, we focused on strategies that are called peripheral, so materials were designed to appear culturally appropriate, evidential, we presented evidence on breast cancer and obesity, constituent involving African-American breast cancer survivors and stakeholders were engaged from the very beginning of even thinking about the intervention. And sociocultural, we honored within this population that we recruited things that were important to them, including the role of God and faith, cancer fatalism, and then linguistic was not relevant for this, but it was relevant for other programs. I'm out of time. Let me just finish up. So we had lots of partnerships that ranged from community-based organizations, breast cancer organizations, academic institutions. Reasons for study participation were, what I was so excited about was that number 3 and number 5, helping others and participating in research were unexpected, and yet it shows that we really have this eager population out there. The intervention was 6 months long. The guided had twice weekly meetings, twice weekly text messaging. The self-guided got the same materials but no personal interaction. And really quick, we saw an 8-pound weight loss in the guided, 2.9 pound in the self-guided. And again, these modest weight losses are what we see in the general population of African Americans as well. I'd like to finish, and with this is the most important part of my talk, I think. What can we do as healthcare providers, stakeholders, researchers, policymakers, and good citizens to make a difference in meeting the needs of diverse populations? We need to improve access to and support weight loss and lifestyle counseling programs, improved insurance coverage, and use of mobile technology. Provide cultural competency training for those working with diverse cancer survivors. This is a huge need everywhere. Talk with survivors about the value of lifestyle changes, improve access to and availability of healthy food choices. There's some great work in changing how corner markets offer produce. Recognize and support community assets and resources such as community gardens, YMs, public recreation systems, and address barriers to language in everything we do. And my last slide, what can we do to make interventions more effective? In short, they need to be multi-level. We need to involve the priority populations and engage community stakeholders. Job opportunities are tremendously important in these communities. Tailor obesity intervention content and structure, provide hands-on learning opportunities, use established settings that are important to the community themselves, engage friends and family, and perhaps the most important thing we can do is to create linkages between cancer survivorship, healthcare, and community organizations. I've sort of coined this phrase of lifestyle navigators. And with that, I thank you for your time.